Assalamu alaikum. Thank you very much for the organizers for giving me the opportunity to present this very important topic. I'm going to start because I think my 10 minutes will finish earlier. Yes, that's what I'm saying. So heart failure, we already know that 64.3 million people suffer from heart failure, and this is data from 2009 actually. So now if we are thinking in 2025, it's 1 in 4 patients are readmitted within 30 days of discharge, and 1 in 2 patients are readmitted within 6 months of heart failure. But with the advent of newer medication, I think this has improved a little bit, especially heart failure hospitalization has improved over a period of time. I'm going to talk about device-based therapies in chronic heart failure, and if we see with last few years, like last 20 years, we have more and more devices coming in patients who have heart failure to ejection fraction, and they are already on GDMT. So always remember, these devices are always indicated in patients who are on optimal GDMT, not before that. Then recent devices which are still in a little bit of investigational or observational studies are cardiac contractility modulation, baroreceptor activation therapy, then mitral valve repair with clip, and now also tricuspid valve repair. I'm going to talk about CRT, but before that, a little bit about cardiac contractility modulation, because a lot of people ask me this question, what is this therapy and what is happening? So it is actually deliver a non-excitatory high voltage electrical pulses to the right ventricular septum in absolute refractory period to enhance the myocardial contractility. Approved by FDA in 2019, but still it is not in guideline. Then baroreceptor activity, or BAT, involves a small device which is put in near the carotid artery, and it addresses the autonomic imbalance in the heart failure patients. It was also approved by FDA in 2019, only one device available commercially, and is still not recommended in the guideline, but in selected patients who are not indicated for CRT, these two options can be used. So what is CRT? So originally, cardiac resynchronization device in 20 years back, what is studies with LV epicardial pacing with transvenous lead insert into coronary sinus and in lateral coronary vein. And then most likely delivered with the ICD, but despite with the improvement of technique, is still in less than 90% of candidates, you can actually find a good coronary vein in which you can implant and you have good results. Especially after the Danish study, if you remember with the CRT, that they did a Danish study in heart failure patients, and they put CRT only, not with ICDs. After that, the indications for the ICD decrease a little bit, especially patients who have ischemic cardiomyopathy or have scar on MRI, they are indicated for CRTD. Rest of the patient who are non-ischemic cardiomyopathy, short life expectancy, major comorbid conditions or renal function, they should be implanted CRTP as compared to CRTD. And then definitely for us, in our economy, there is a huge difference in the cost of two devices. Various trials over the period of time have proven that CRT has a benefit in both in mortality and morbidity with prolonged QRS duration. So what is the most important thing when you're putting in a CRT? So when you're putting in a CRT, you have to have an optimal left ventricle lead placement, which can be CMR guided or CT guided also. Or if you are not able to, that means you have to stimulate the native conduction system, and which brings us to the conduction system pacing. What are the conventional challenges in conventional biventricular pacing? Usually acute procedural failure, frank nerve stimulation, lack of adequate venous anatomy. And then if we think physiologically, we are still stimulating heart from outside epicardially. So the myocardial depolarization and repolarization is reversed in BIV, and if is compared with the conduction system pacing, the myocardium is actually conducted endocardially like normal conduction system, if you are able to have the conduction system pacing. This is a concept start with his bundle pacing, high pacing thresholds frequently observed, and then risk of distal conduction block. After that, they come up with left bundle branch area pacing, which include pacing of the main left bundle branch or left vesicle or left ventricular septal pacing. It is considered faster, less complex, and higher success rate. So if we want to start, the most easiest case to do is a patient who has atrial fibrillation with slow ventricular rate, because you don't want to do RV pacing, and you just put a single same pacemaker lead near the left bundle. And how you're going to find the left bundle? Left bundle is just below the tricuspid valve annulus. And with Medtronic, you have a specialized lead and sheath system, but rest of the vendors, they are using the same leads, stylet-driven leads, with specific sheath, which actually are preformed to keep the leads at the septum. And after implantation, after implantation, if you see the ECG, the QRS actually mimic the normal narrow QRS complex, which should be happening in the patients. Other options, what is happening is they are combining left bundle branch area pacing with CRT. So now, we don't have still a lot of randomized trials. We have observational data in which they have compared left bundle branch area pacing or conduction system pacing with CRTs, and all of them approved that it improved ejection fraction and also NYJ class. So recent consensus document proposed how you're going to see if we are achieving left bundle branch. There is the QRS transition in selective left bundle branch area pacing during threshold testing, V6 R wave peak time, 44 millisecond, and QRS transition to selective left bundle branch during program stimulation. Here you can see, if we start from V1, the initial two complexes, they are ECGs from 3 different patients, which we have done in NICBD. So we start with the non-selective left bundle branch capture, and then at the end complexes, you can see we have a selective left bundle branch interaction, and you have a huge R wave in the V1. That is one of the criteria. And then V6 P wave R wave peak time is also narrowed to almost 40 millisecond. Complications of the procedures: acute septal perforation, lead dislodgement, lead fracture can occur, intraventricular septal hematoma, and then RBB injury, coronary artery injury, most frequently to the first septal perforator, and worsening tricuspid regurgitation. So what are the recent guidelines? In March 2025, European Society of Cardiology have issued a clinical statement. In patients with AV block, if you are anticipating less than 20% V pacing, then we can still go with the RV pacing. But if you are anticipating more than 20% of pacing, then it should be conduction system pacing or bi-V pacing. With the conduction system pacing, the important thing is that we are actually decreasing the cost of the procedure for especially countries like us, low middle income countries, because we can use the same pacemaker which we are using for the pacing, and the leads are the same, just the way we are implanting it, it's a little bit difficult with the RV lead which we are implanting in the apex or septum. So we are now targeting the conduction system directly. So the end result will be not a broad QRS complex, but a narrower normal QRS complex, which is going to result in resynchronization. All the patients who have CRT indication can be implanted conduction system pacing. And AV node ablation. In patients with persistent AFib who have heart failure and you cannot control the heart rate, you can do the bi-V pacing and conduction system pacing. Future perspective, lot of clinical trials are ongoing, which are going after which I think it will be a class 1 indication as comparable to the bi-V pacing. So in conclusion, it represents a true paradigm shift, especially countries like Pakistan, provide functional resynchronization with a single lead actually. And technological improvement are coming, and the criteria of left bundle capture need a little bit more refinement. But it has a potential to completely actually prevent the pacing-induced cardiomyopathy. Is still used as a bailout, but can be used now as a first-line procedure in patients in which we think that we have to implant CRT and we are restrained with our cost. We can use left bundle branch area pacing, and we can have as comparable result as the BIV. Thank you.